Awesome. Thanks so much, Diane. It's always kind of a treat for me when I'm invited to do stuff like this, but also a little bit curious because as most of the MDs in the audience will tell you, they don't actually teach us a lot about wound care in medical school. And I'm a general surgeon by training, so the only wounds that we learn about are the ones we make ourselves. And then I did a colorectal fellowship, so I know a lot about hemorrhoids. But not so much about wounds. But about 10 years ago, I was asked by our VP of medicine to be the physician lead for our regional complex wound clinic. And so I think they sent me to a weekend course in San Antonio. That's the extent of my training. And then over the last 10 years or so, I've learned things here and there from people like Rosemary and from people like all of you. So I am so incredibly grateful for my time in wound care and for all of you and the work that you do. It's incredibly important work. So again, if you have a tough wound care question afterwards, it goes to Rosemary. If you have a hemorrhoid question, you can ask me. The objectives today are, I'm going to give a brief overview of diabetes in Canada and an overview of the pathogenesis of diabetic foot ulcers. We're going to tell you about a new initiative we have in BC that funds orthotics for people that are healed by total contact casting. And then Rosemary is going to talk about some case studies using the two modalities, Hydrofera Blue and then total contact casts, and then we'll take some questions after that. So again, that's me. So diabetes in Canada, all of you know that diabetes is the modern plague. It's estimated about 30% of the population, about 11.7 million Canadians as of 2022, have either diabetes or a pre-diabetic state. If you have diabetes, it is associated with a lot of different complications and bad outcomes. In fact, if you have diabetes, you are 3 times more likely than the general population to be hospitalized with cardiovascular disease. You're about 12 times more likely to be hospitalized with complications of end-stage renal failure, and then about 20 times more likely to require some form of lower limb amputation. Now, diabetes also doesn't play fair. It picks on the weak and the poor. So there's lots of socioeconomic factors. The prevalence of diabetes in the lowest income group about 5 times higher than the general population. If you don't have a high school education, about the same. And then if you're unable to work, if you're unemployed, 3 times higher prevalence of diabetes. Now, because we are going into Truth and Reconciliation Day on Saturday, I just wanted to take a moment to talk about diabetes in Indigenous populations. We have about 1.7 million Indigenous peoples in Canada. Their prevalence of diabetes and pre-diabetic state are about 6 times those of the average population. And their risk of lower limb amputation is about 38 times the national average. Now, you might remember in the previous slide, it was 20 times higher in diabetics. So why is it twice as high in the Indigenous population? Well, it probably has something to do with differentials in access and treatment in Indigenous peoples. All right, so diabetic foot ulcers, which are a pretty typical one shown here at a metatarsal head on the plantar surface of a foot. So diabetic foot ulcers are associated with a 50% 5-year survival. Now, take a moment to think about what that actually means, because we all see a lot of diabetic foot ulcers, but this means that when you see somebody with something like this in your office or in your clinic, that half of them are going to be dead in 5 years. And think about, how that relates to other disease entities that you deal with. In fact, if you have a very common cancer, all comers, not late stages, like prostate cancer, like breast cancer, like Hodgkin's lymphoma, your 5-year survival is somewhere between 80 and 90%, so much, much higher than diabetic foot ulcers. And, I think the only things that sort of approach this sort of survival rate are really advanced cancers or diabetic related complications that end in end stage organ failure. So if you have diabetes associated renal failure, or if you go blind because of your diabetes, then you have a similar survival rate. But when we see diabetic foot ulcers, we often think, well, it's an inconvenience, or sometimes they get infected, sometimes they'll get osteomyelitis. Sometimes they'll develop infections so much that you have to send them to the emergency department, or they get hospitalized and they get septic. Sometimes they require an amputation. But what this stat tells us is that half the time, within 5 years, the ultimate pathway is death. So there is a lot of urgency to not only treating these things very, very well, but trying to avoid them in the first place. So why do diabetics get ulcers? Well, we all know there's lots of factors in diabetes that lead to poor wound healing. So if you're a diabetic, there is a level of immunosuppression, so they are susceptible to poor wound healing. It takes a long time for some of these wounds to heal. We also know that if your blood sugars are high, the effects of smoking are potentiated. There's effects on your microvasculars, particularly the small vessels and capillaries, which get obliterated. And the list goes on and on. I'm a general surgeon, not a real doctor, so you'll have to ask me, ask somebody who knows something about diabetes to get the full story. We're going to specifically talk about neuropathies and their role in the pathophysiology, pathogenesis of diabetes. So because diabetes is such a multifactorial disease, our approach to diabetic foot ulcers also has to be somewhat holistic. So again, first thing when we're approaching a diabetic foot patient is you need to control their diabetes. Again, usually for me involving someone else like a family doctor or an internal medicine doctor or an endocrinologist or even a diabetes educator to help them get their blood sugars under control. Because there are microvascular effects of diabetes, often there's a vascular assessment. I always get x-rays on my diabetic foot patients because diabetes, again, is associated with changes in structural features of your foot. As with any wound, there is an art and science to treating those wounds, and Rosemary's going to expound on that a little bit later. We're going to focus here mainly on offloading. So again, one of the end organ failures that you experience with advanced diabetes is something called a neuropathy. All of you know there are several types of diabetic neuropathy. We're going to focus on the one on the left, the large fiber neuropathies, which results in something called a glove and stocking neuropathy. So they start with having no sensation in their toes, and that sort of slowly over time moves up their legs, and then eventually affecting their hands as well. And just to the middle and the right of this figure, you can see the different points that if you had your standard 2-gram monofilament, you'd be testing to check for a neuropathy. So how do most diabetic foot ulcers form? Well, when you walk, there are always areas in your foot that are subject to higher levels of pressure and shear force or friction. If I was to develop a diabetic foot ulcer, I know exactly where it would be. It would be on the outside of my left heel, because that's where I experience callus formation. And you all know that calluses are not normal tissue. They dry out, they're non-vascular. And what happens is eventually, because they're inflexible, they dry out, they crack, and that crack can eventually lead to ulcer formation. Now, if you have normal sensation in your feet, that generally is when that crack stops. It doesn't progress because it hurts when you walk on it. I know that's the case with me when my callus cracks. I take good care of that area because it hurts me when I walk on it. But obviously, in a diabetic with a neuropathy, you don't have that pain feedback, so it just progresses. And often diabetics with foot ulcers are unaware that they even have an ulcer until they have like a bloody sock, or somebody notices a unique odor coming from their feet, and that's when they actually seek medical attention. So often it's quite advanced by the time they seek attention. Now, obviously, because the primary factor in developing these ulcers is pressure and friction, the primary modality for treatment, the central tenet, is offloading of your feet. And this is for the treatment of ulcerations, but also for the prevention of diabetic foot ulcers or the avoidance of recurrence later on. And there are several modalities listed here. I'm going to specifically talk about total contact casting. There's an example here. Giselle, do you want to lift it up and show everyone what a total contact cast looks like? It's nothing fancy. It's a fiberglass cast, as if you had broken your foot. And, you know, this is obviously not something that you would use for prevention, not something for avoidance of recurrence, but this is something we use for treatment when patients actually have diabetic foot ulcers. It is very, very good at redistributing the forces around the foot so that one area isn't subject to more pressure or friction. But more importantly, there's nothing particularly magical about the fiberglass or the materials themselves. They do provide an element of compression because you have to apply them quite tightly so they don't sort of jiggle around. But they're also heavy and cumbersome. So patients tend not to walk very much. And the most important thing is patients can't take it off. So at 3 o'clock in the morning when they have to get up to the bathroom to go pee, they can't take it off. They can't take those few steps that actually slough off skin cells on your healing diabetic foot wound. So there's lots of reasons, even though we know that the central tenet to treating diabetic foot ulcers is offloading, there's lots of reasons why patients don't get offloaded. Some of them have to do with wound factors. For example, with total contact casts, it's not particularly good for heel wounds. It's much better for metatarsal heads, that sort of thing. There are education factors, for nursing. It takes a degree of training and supervision to actually apply them appropriately. And then there's things in the system that just avoid, that prevent you from adequately offloading. Again, for example, if you need to drive to work and your diabetic foot ulcer happens to be on your right foot, well, you can't have a total contact cast then. But I find that the primary factor in a lot of cases that things like offloading orthotics and shoes are just very, very expensive. They can cost hundreds to thousands of dollars. And again, diabetes isn't fair. It affects the poor more than anything, and they just can't affect offloading. So as of January of this year, the Ministry of Health and Pharmacare and a lot of local stakeholders like Rosemary, and she's going to talk about the process of actually getting this initiative, the Ministry of Health has decided that they will fund offloading orthotics for patients who have been healed by total contact casting. Now, you might think that this is a very, very restrictive criteria. It's actually a very small number of people, but every little bit helps. And I just want to emphasize that this is a starting point. And, there's other future possibilities. Eventually, we hope that the government will move to fund orthotics for everyone. And then we would like them to fund something that's not so reactive. So again, total contact casts are for people who already have foot ulcers, but why not fund them proactively upstream to get these people regularly checking their feet and then funding orthotics to avoid a new diabetic foot ulcer or recurrence. So I'm going to pass it off to Rosemary now, and she's going to tell you a little bit about case studies.
Okay. Great. Thanks, John. Just in case I need your help, just stay close. Okay. Yeah, I sure like that thought. Could you imagine if we were more preventative, where instead of just focusing our energies when the ulcers already happened? So anyway, but let me walk you through some of the the interesting stuff that's happening in BC. And Janet, I think you're here today. Where are you? Where are you, Janet? Did she step out? Yeah, she was here earlier, but she did a nice interview with John and also sort of talked a little bit about some of the work in BC and emphasized some of the benefits now that that can occur in our province. So what I want to mention to you is something called the CLIC website, the Connecting Learners with Knowledge, clw.ca, because there are more details there related to the BC program. Okay. We would be remiss if we didn't talk a little bit about what's out there in terms of the evidence around the prevention and management of diabetic foot ulcers and wounds. Canada has a wonderful document there, but also there's the international guidelines as well that's published, and they have portions respective to offloading. But you know, one person who's has many publications is Dr. David Armstrong. I'm sure many of you have heard of him, and he really helped establish in some of his early published works around the gold standard of total contact casting. One time I was at a European conference and I met him and I thought, oh, that's David Armstrong. He was very kind. And I said, do you mind if I just get my picture with you? So that is David Armstrong. But how many of you have heard of Dr. David Armstrong? Yes. Okay. All right. So how many of you had your picture with him? Sorry. Anyway, it's going to be a lineup later and you can have your picture with John too, but enough. Anyway. Oh, with Barbara Braden. Oh, wow. That would be, yeah. You know, there's something, you see, to me, those are like little cornerstones because when I met him, I was just starting to do the total contact casting. And it was like, wow, you know, and I'd gone back to a lot of his research. So, you know, we're going to take you through a number of videos too. For some of you, so I've been doing total contact casting for almost about 5 years in my ambulatory clinic setting, but also I have a cast clinic, and I find the orthotechs so helpful because they help remove the cast for me when the patient arrives, and then I am the person who does apply it. This, by the way, is we use a bolster. Not quite there, actually. Typically, the bolster is up the leg, but I was positioning his foot. You'll notice he's missing his first digit, but I was just going to do some wound care to an area where he had previous had an amputation and he had a wound. I typically use Hydrofera blue transfer because I find the wounds there have a lot of exudate, and it's lovely to transfer that exudate to a foam dressing. So after I've done suitable wound hygiene, then I go ahead and apply the transfer, secure it, and then my next steps are going to begin applying the TCC. It's always important, though, to protect his other toes. So I have little 2x2s in a particular kit that we do that. We'll move along here, and you'll see me once I've done his dressing care, I go ahead and I apply a sock all the way just above his knee, and we move that along. And I make sure afterwards I'm careful not to scooch that dressing out of place. So here we go, and we're going to watch through a series of videos, me putting on the total contact cast. Now, there really is a learning curve with this. Okay, this isn't something that you do one and then you're on your way to do them on your own afterwards, because you really want to protect the pressure point areas. And so there are strips where you want to protect bony prominences, or you want to protect the malleolus, the medial and the lateral malleolus. And also you put a reminder strip as to how high I'm going to apply the total contact cast. Once I've got the suitable protection on, after I've put his sock on, I then begin to put the toe box protector. And this all comes in the kit. And I fold it over very carefully, making sure there's some nice space for his toes. Then I trim that, and then I begin to put some padding on. Now, I will tell you, in my early years, it did take me a bit of time, but like anything, you become familiar, and usually I can put one on within 15 minutes now. It's probably because of the kit that we have, and it comes with 2 soft rolls to wrap around, and you're doing that padding because there's risk associated with pressure injury. And then there's 5 rolls. I take that first roll and I do my nice toe box around with that first roll that I've dipped into warm water, squeeze, pull out, and I begin to do that. And usually the patient has the bolster under their thigh and they keep their leg up, and off I go. And then I continue to move my way up the leg, and the packages are nicely labeled, either 3-inch or 4-inch. And I get that. I usually, because there's fiberglass, I throw a gown on, but I also have a board, a chopping board, because sometimes I lean the chopping board up against me and I make sure the foot is in the appropriate sort of dorsiflex position. Do you know, though, that sometimes when it's my first time on a patient, I pull on my orthotech. I mean, they're doing them all the time. And I'll just say, hey, Bev, new patient here. Just make sure I've got all the right angles and I'm doing it correct. Because they're experts at cast application. And so once that's on, then the person, what I love about it is that once I've done it, literally I put the shoe on and the person walks out the door. It dries that quickly. That's why from when the initial application to the patient leaving, 15 minutes. Now that comes with experience, not at the beginning. And it's good to have a person watch you do it several times, because if there is any degree of vascular issues, you sure don't want to cause another pressure injury, because you don't want to have anything that's going to also be later troublesome to heal. We also have created, we're just doing final touches, literally like today, right now, back in BC, the provincial skin and wound meeting, they had their face-to-face meeting yesterday and today, and they're finalizing this document literally on the how to apply it step by step. And then what they're going to do is they're going to do a video with me. And so they'll have this quick video showing the application of it. So stay tuned, and that's available on the Click website. That's the kit. So simple and easy. The sock is there, the rolls, and off you go. I really want to, highlight some of what Diabetes Canada is also telling us, and they announced that as of January 1st, we began this new process in BC that if a person who was a diabetic, had a diabetic foot ulcer, was being seen by an NSWAC and was receiving total contact casting, that then they would be eligible to this BC program. And so I began to put people into the program. Now, one of the things I would love for it to be expanded is because I see some patients who are not diabetic but have neuropathy. So I must quickly underscore the fact, initially we're starting with patients who have diabetes, okay? I think that Diabetes Canada, Wounds Canada, and the Canadian Podiatry Medical Association applaud the new policy that we've got going in BC. It's a beginning. And we're going to be looking, actually, at the beginning of January, we're going to evaluate all the people that we put into the program to see are there areas where we can improve on? Because it's you put something new in place, but you've got to look back to see how can we improve, but more importantly, how could we maybe expand the program so it's not quite as restrictive? And so Diabetes Canada is very excited about some of these early innovative options to help those who it's difficult to afford some of the orthotics. And I'm going to walk us through one of my cases where it was very beneficial, where the person had a limited income, would not have been able to afford the orthotics, so that once we had his wound closed and healed, he would avail himself to a listed area in Vancouver that was associated with this funding opportunity. I did take the time because this is kind of exciting work. I will say that the work fell out with Shannon Hanfield, myself, and a member from the Ministry of Health called Lori. And so after we put this all in place, we thought it might be worthwhile to do a poster on it. So there is a poster here for you to get a little bit more information about the process that we took in British Columbia, where we began to meet. It was a bit of happenstance. Lori, we were working with Lori because of patients who have ostomies and how to streamline the support and products for ostomy support. But Lori then received information from the Ministry of Health to say, look, can you put a pause on that, switch gears? Let's start focusing on people who have diabetes and how can we offer some funding support? That's when she reached out to Shannon and I. And then what we did was we pulled together all the NSWACs in British Columbia who do total contact casting. And we had an ad hoc group, and we began regular meetings to see how could we formalize the process of somebody who has a diabetic foot ulcer, avails themselves to one of the clinics in one of our health authorities, receives it, the appropriate paperwork. It's not too cumbersome. And all of those things, there's actually 4 items there on the CLIC website, but also on the poster, you'll see the link related to that information. So you can see there was some earlier work with the Ministry of Health back in 2019, but we really formalized the process June 2022, where we really began to have those regular meetings. And I like that those meetings included not just nurses, but OTs and physicians around some of that offloading work. Okay. And so the results are what you'll see as of this January. By the way, we've just created a brand new Excel spreadsheet that's going to be the part of the evaluation. And each health authority is going to put down some of the data that we've done. So there's the resources, and there's 4 items. One of the items just lists the particular areas that you need to send your patient to, depending on where your patient lives. So for Vancouver, I send them to Vancouver Orthotics because it's deemed to be a place that the Ministry of Health is connected with. And then also there's a list of the clinics within BC who do total contact casting. And then there's a very simple referral sheet. So when I've got my patient coming in, I just recently had one, I get the paperwork going very simply and zip it off to Vancouver Orthotics, and then I begin planning the appropriate follow-up. So let's take our case. Let's talk about John and his wound, diabetes type 2, and there he is with that, the first, I don't know what you'd call it. Yes, it's a first met. He's lost his toe, and we started the TCC, the complete offloading. And you can see again, it's fairly wet, so I tend to use the transfer. I always use the transferring it to an absorptive dressing, but you'll see how fairly quickly that offloading, you get those results, right? Because there's no pressure, not a lot of friction and shear. And then he followed with Vancouver Orthotics, and they provided appropriate shoes and orthotics for him. Now, you might say, were they free? Did John get that free because of the Ministry of Health? No, but he was certainly in the program, but part of it was his deductible. So I want to make sure that John and I are really transparent here in that saying we don't want to say that everybody who's diabetic and we do TCCs will have their orthotics for free. It's exactly based on for BC, their fair pharmacare and what their deductible is. It's actually, for those of you who are ostomy nurses, it's exactly the same as ostomy care. So my patients who have an ostomy, the government doesn't pay for all their ostomy care. They look at their BC Fair Pharmacare, they look at what their deductible is. Then, when they reach their deductible, the government will kick in and support them. So some of my patients, by the time June or July rolls around, they're no longer paying for their ostomy supplies. I appreciate that every province is different, but I just wanted to, maybe give a bit of details on how that funding works. Now, Steve, I think, is at the back there. I was telling him I've got this video, but I'm not sure how well you can hear John. So if he's going to maybe put up the volume if he has to. And we're going to hear from John about what it's like to be in a total contact cast. You've done that a couple of times, so just go ahead, share your story.
Well, sadly, it's not my first rodeo with one of these, but generally speaking, I found the experience very positive. I mean, obviously, it's a big, hard, heavy cast. It's not that heavy, but it's not the no, it's not what you want to be wearing to the beach. But it's not that obtrusive, and it really does a good job of healing the wound, which is on the I had a toe amputation, and it's at the site of the amputation. And it heals it up quickly, and my experience has been really positive. It's it's a whole lot better than the alternative, which is the wound not healing.
And I'm noticing, John, it's your right leg. So that's your driving leg. When we start to do it, do you do some preparation there?
Well, I'm very fortunate, but anybody who has a similar problem would have to sort of prepare not to drive. But I'm very fortunate I can work from home, and when I do have to go into the office, transit is pretty good for me. So, but like all things, even in the cast, I'm trying to keep off my leg as much as possible. So, working from home is a good option.
What about sleep? What about during the night?
During the night can be a little bit of a problem. I would recommend a leg sock for the other leg. This is actually, Rosemary, you can correct me, but it's fiberglass.
Yes.
So if you bang the cast into your other leg, you're going to end up with abrasions, which I have, but they're not deep or serious. So I've learned to cushion the other leg. A leg sock works, pillows work. If you can get a pair of pajamas on over the top of the cast, that works. And that's another thing about the cast. Always, in preparation, I would say always wear shorts if you can. Or today I have a nice loose pair of trousers so that it hoiks up.
Right.
Fairly easy. I'm not sure that hoiks is a commonly used word, but
right. Yeah. All right. That's great. Hey, thanks, John. We certainly have had considerable success when we do the TCC with you. So, and it's you that's often will ask, maybe at this time, so that tells me your receptivity to having a TCC. You see the value.
Yeah. It's also really important to have a plan for after the TCC, and I've got a great team at Vancouver Orthotics who are continually modifying my footwear to try and offload the site of the injury, and we're making progress there as well.
Excellent. Really good point. Thanks so much, John. Really appreciate it.
Okay.
Well, he makes such a good point there, isn't it? because once they come out, you've got to have a plan. And so I start working on that plan. I usually, even if he's closed, I keep him in the TCC another week or two, just to ensure we've got some really good, decent closure. Now, this is a gentleman who actually did avail himself to the orthotics after the TCC, and he was in a range where he was eligible and he didn't have to pay for his orthotics. So there's a 54-year-old, and again, after I do a suitable wound hygiene, cleaned it up. There was some depth. It may not look big and huge like John's, but there was depth, and we were not making progress until we started the TCC. And then each time I would tend to do a little bit of callus paring down to the point that he's closed and healed. And you can see it didn't take that long with him using the transfer. And so he went ahead and did get the orthotics through Vancouver Orthotics. I also want to take this time just to talk about other patients with diabetic foot ulcers and some of the strategies. One of the things, it's sometimes a bit easier when the diabetic foot ulcer is on the dorsal aspect of the foot. This guy came and it was looking so bad that they had talked to him about an amputation. His foot was red, inflamed, swollen. We thought about doing surgery to do debridement, but he had declined some of those options. So what we did, and he was presented, if I go to his chart, his only option, it even said, was a baloney amputation. So, which is pretty, as you can imagine, life-changing. So what we did was I began to do conservative sharp wound debridement, but right away put him in Hydrofera Blue Classic. Now he had a lot of drainage, and I actually even had to change it daily. So we kept that going, and you can just see how it cleaned up, and then we returned him back to Seashelt, just continuing in the classic to the point where he closed. So that's a really good, it was an excellent example where you see the classic as it dries out, as it works, it really picks up that devitalized tissue in his wound bed and gives you suitable wound hygiene. This was another 60-year-old lady with chemo. Veronica definitely, as all my patients with these photos have given consent, and she had gemcitabine related to one of her cancers, and so she had a necrosis happen to her toes, right to the point where there was bone exposed. And so what we did was we just went straight to Hydrofera Blue, and you'll see over the course of those dates how she went ahead and closed, because sometimes people go, ooh, is it something I can use over bone? Absolutely. There was no issues whatsoever. And she was a very brittle diabetic and also at the time receiving chemotherapy. So it was impressive, her healing. I want to share another story because this has an important implication. And it was a 72-year-old lady that came to our medical day center clinic, and her foot looked terrible. It was swollen, it was red, and the opening on that left foot of hers went right through, that's the bottom of her left foot. But a key piece is whenever you're looking at a diabetic, pull the sock off the other foot and look at her right foot. Look at that callus, because I remember looking at her foot thinking, oh no, she's a below knee. I wonder what her other foot is like, because it's going to have to handle a fair bit of the issues. So I want to show you, I'll go to the next slide. We brought in orthopedics, of course. We went to the OR. There's a little bit of fuzz on those pictures, just we took them in the operating room where Dr. Bagu did a nice debridement. And then I went back, because it was busy those days. I went back to her callus, pared it down, and lo and behold, as I squeezed it, pus came out of there as well. So interesting. That's anything foot related. Always remember, look at that other foot as well. So the debridement occurred in the OR. We did start off with some negative pressure wound therapy, and then we proceeded on to moving her. She was from Seashelt as well. And so we just moved her to the classic, but a really nice result. How do you like that callus on her right foot? All gone. Of course, you see, I had the opportunity where she wasn't weight bearing as much because she was in a hospital bed and we were providing her with IV antibiotics to deal with the bone infection. But so I felt we left her in a good place, and she went on to close. And at that time, I used the Hydrofera Blue Classic. Now we have the border, and I might have switched her had I had that at that time, because you see, the Hydrofera Blue, it's a family. There's a whole line of products that you can pick and choose from as the journey of your patient and their wound. Our wounds are dynamic. They're not static. And so therefore we have to reach for that right dressing and its qualities. And so, yes, we uphold the wound bed preparation. We've seen this over the years, and where we've got DIME or time, the debridement, infection management, moisture, and edge. And this is where I'm excited to say that the Hydrofera Blue Classic will capture each one of those areas, and it can be used wherever your wound is in that journey. It addresses all four factors. So, one of the things is the Hydrofera Blue, in case it's not familiar to you, it does change color. And it turns white. And in fact, at that point, it's lost its fight. So that's another good indication that clearly it's time to change the dressing. And so, and sometimes I've gone ahead and used it with negative pressure wound therapy. We'll come to that. But I think one of the things, just to quickly highlight, as I see my time is going, but I want to remember that it's non-cytotoxics, that I certainly have used it in my pediatric population as well. Stephanie Furtado did some wonderful work with her neonates and using Hydrofera Blue Classic. But also it also manages yeast. And so sometimes we think of bacteria, but I think it's important to mention that as well. But another little feature is it can flatten, the Classic can flatten some of the rolled wound edges if you make it a little larger. And so then you can get that nice epithelialization. So we've got transfer now, which we've been using a fair bit, and certainly we use it for our TCCs, but you can use it between toes. There's a variety of areas where you can use the transfer. Hey, quick show of hands. How many of you here have heard of transfer? Okay, so I think you're going to have to go to the booth and just do a little more exploring around hearing about transfer and grabbing some literature on that. You'll see how it turns white when I use it with my diabetic foot ulcers, and I tend to get less maceration. Can use it under feeding tubes because it's transferring out that exudate, but has an antimicrobial aspect, as well as around the trach site. Sometimes you can get those difficult trach areas. And so that's another, I'm just kind of throwing ideas at you, and you probably even have more. Of course, you can use it under compression as well. And in between the toes. And there's the border as well, that is now available to us and can be used in some of those tricky spots, whether it's elbows or heels, when it's hard to just get that dressing to conform. Quickly, this last case study was a woman with diverticular disease, and she had had a Hartman's, and then, of course, wound dehiscence, and things were looking really, really messy. And so kind of went with something a little different, went a little rogue there. Rosie going rogue, but maybe we'll have to start a song on that. And we'll shoot some videos here where it's the Hydrofera Blue Classic, or we can use the heavy. And the heavy is quite thick. And I'm going to do the next video where you can wring it out. You dip it, you wring it out, and then you kind of cut it. I call it like a mosquito coil. And then take that dressing and slide it into the wound bed. I was preparing because this lady was from a rural place, Bella, and their ability to do a negative pressure wound therapy was limited. So I thought if I can step her down to going to just the Hydrofera Blue Heavy and transferring her back home. Home was important, and it was around Christmas time, so you can get creative, but you can also, I've done both with using that plus negative wound therapy, um, negative pressure wound therapy, but you can see how it really had an ability to clean up that wound bed. Now, look, talk about versatility. Some patients that I have it's just not safe or suitable to have them going out with a portable negative pressure wound therapy. But sometimes there's those smaller devices, such as a Pico. And I often will do Hydrofera Blue Classic under a Pico. And that for some elderly people, or in this case, it was a young guy where he had exposed hardware. And so we were able to use the Hydrofera Blue and a Pico. And that also helped facilitate some closure. I'm coming across, maybe it's our population, more elderly people. And, they're at risk for falls and carrying a machine around. So I want to be very careful about my choices in dressing products. And some people from a pain perspective, they just can't handle it. And so I just saw a lady on Monday where she had a large squamous cell carcinoma removed from her chest. Anyway, the incision fell apart. So she has an 11 by 8 centimeter wound on her chest. Well, it's not suitable for her. She's 90. And so what we're going to do is I'm going to use the Hydrofera Blue transfer, something gentle just to transfer the exudate. Got photos coming. Maybe that'll be next year. I'll have to share with you her story because not everybody can carry around a little machine. And so we have to think of options that offer quality of life and comfort. And so remember that there is some element of negative pressure wound therapy with just the classic alone as it dries and how it draws up some of the devitalized tissue. You all have a pamphlet, I'm hoping, at your tables where there's more information on this. And so I guess as I conclude here, why do I choose it? I love that it's non-cytotoxic. I like that I can go even up to 5 or 6 months if I needed to use it. I don't have sometimes the restrictions we have around silver dressings. It does seem to disrupt that film or devitalized tissue on the wound bed. And there's versatility. I like to use the tunnel sometimes when I have some narrow sinuses. Always remember, I love this, that Dr. Kevin Wu brought us the notion of both upper and lower infection. And if we saw signs and symptoms of that in terms of 3 or more, we were to consider perhaps upper infection when you look at the words associated with the letters UPPER. I think, Diane, are they going to have some of those in the booth? Yes. So if some of you want to have that nice little card, it's a great guide because when you speak to a physician, you can be objective and you can say, I'm concerned about this wound. Why am I concerned? And particularly for those where it's lower, where you're thinking you need the antimicrobial support. And so I think that will be something that helps you when you have the dialogue with the physician. And you can be specific other than saying, you like that, right, John? When people come and be specific, as opposed to, I don't know, it just doesn't kind of look good, it smells kind of funny. And so these things, I love that tool. And it's a helpful reminder.